Good afternoon to everyone. After such an exciting inauguration and felicitation of all the seniors who have actually brought this forum into existence and have really helped to spearhead the North Zone, we welcome you to this infertility panel. We have 45 minutes exactly and our time starts now. So basically we have actually brought together, Renu has actually worked hard, I haven't. So we've brought together a couple of cases from simple to more complex, and we have a galaxy of young girls sitting here to answer our queries. Also we have three very renowned experts sitting here from the North Zone, Dr. Khemani, Dr. Rita Bakshi and Dr. Arun. They shall be intercepting in between. We won't give them much time because of lack of time, but definitely we would ask for their expert opinion on the various cases. So, and you know, basically we all have to understand now whether we can really practice infertility the way we were, because we are now bogged down by multiple acts, the PNDT Act and the ART Act. So that is why whenever you are thinking of any infertile patient, think of the two acts before you answer a question. Okay, do I frighten you? No. All right, so we come with the first case, and the case is a 37-year-old female and her partner is 38 years. They've been married for 10 years, trying for 5 years. Both are chronic heavy smokers with she has regular cycles, but her cycles have suddenly become short since 1 year. 2 days and 21 to 23 days, bilateral spill, partner histories of erectile dysfunction, and the semen shows mild oats. Her day 2 hormones are also borderline FSH 12, E2 90 and AMH 0.8. Now my question to Amrita. Amrita, very short. What is your advice and how are you going to justify that? 1, 2, 3, 4. That's it.
Wife 37 and husband is 38 years, and both are smokers. Even the hormonal levels are not in favor.
3.
And the semen analysis is also not in favor.
4.
So the counseling is the backbone for this couple, and first of all they need to quit smoking. Then the ultrasound of the lady should be done, because AMH is just a screening here. We should know the antral follicular count of this patient, and we should also...
Let me change the question. Let me change you. See, we want very short answers because we have to ask all of them one.
Yes, ma'am.
Now this file has been sent to you with just this information, and you have to give a suggestion. What do you want to do for her? IUI, IVF, or leave her alone?
IVF.
How are you justifying that? 1, 2, 3, 4.
Yes, ma'am. IVF, because the age is the most important factor, and the sperm count, oligoasthenos teratozoospermia is there. So a proper semen analysis and DNA fragmentation of this person should be done, and he should be suggested he might need sperm extraction.
Okay.
So that is there, and the lady should also be suggested oocyte donation. I mean, they should be told
All right.
about that.
Now let me ask Rita. Rita, 1, 2, 3.
So I think absolutely she's 37, married more than 5 years, oats. There is nothing else except doing an IVF, and of course lifestyle changing, antioxidants and all that before taking the sperm, or doing a TESA and then doing an X.
Thank you. So both of you, you are passed now because the expert agrees with your opinion. All right, we go on to the next case. Patient is 35 years, married 9 years. She ovulates every month. She has regular cycle. Tubes are healthy. Male factor is normal. 3 failed IUIs, and she is currently unexplained infertility. Poonam, what is your advice to her, IUI or IVF?
My advice will depend upon 3 things. First of all, I need to know her AMH, I need to know her AFC, and then you are saying male factor is normal and everything rest of the things are normal, but I need to see her previous papers also, how that IUI was done, because we all know the status of IUI, where it is done. We just need to see all those papers, whether the justified IUI was done or not.
Very good.
If it was justified and you find that everything is okay and her AMH is borderline, and then final is their, ball is in their court, and we have to explain and tell them all the consequences and what will be the result with IVF and what will be the result with IUI, and then we should go ahead with the with
So in
whatever
honest-
the, but if they ask me, then I will do one semen DNA fragmentation also, and then I will proceed for, after examining and doing, since she is already 35, already 9 years, I will suggest, if my suggestion is asked, I will suggest IVF.
IVF. So, Dr. Arun, to put it shortly,
Yes, ma'am.
what is a better method, IUI or IVF in unexplained infertility? What is the success rate like in expectant management, IUI and IVF?
I still find-
she says IVF.
I
You
still-
think she's justified?
Not exactly. What my thought is that, see, previously we were saying 3 I failed IUI and then finish off,
Yeah.
then shift to IVF. The personally telling you, and then many studies are also coming that you can go on with IUI now up to 12 cycles. When she is all right, you may not, but this is what literature tells me, but you may not go up to 12 cycles, but then you can still continue with IUI, taking care of rest everything. This is what my thought is.
I think Dr. Manju Khimani begs to differ. Yes, Manju?
Ma'am, I think in the cases of this unexplained infertility, as the patient age goes on, our results on IUI, they tend to
Absolutely.
decrease.
So there is a factor over here. She's 35 years of age. Yes?
Highest pregnancy rate in IUI is in the first cycle.
Yes.
Then decrease, third cycle is 4%. They've already tried 3 cycles.
So IVF, okay. So basically, if you look at this chart, you see that whether it is versus expectant, whether versus IUI, whether versus IVF, everywhere IVF is giving us the best results, borderline. But again, as Poonam has very rightly said, it depends on the various factors that we still have to find out. We don't know her AFC, we don't know her AMH, we don't know anything about the IOs that were done. It may be just kachra. So therefore, we have to give her the best chance, and I think you're absolutely right. Thank you, Dr. Arun.
Can I just add one thing? Please do not do so many IUIs that there's nothing left for IVF.
Yes,
Very,
that is
very sincere
important.
request.
Very important.
Not only her anatomy, but also her finances.
Yeah, finances, of course, but
Finances and her
Everything
psychology.
goes
say,
away.
so
Everything goes away.
people keep on doing IUIs to a point where even IVF success rate goes down.
Yes. Okay, so this is a third case that we have, and basically this is a 31. Now she's a young girl. She's 31 years for a change, coming to us at 3 years after she got married. Husband's semen is normal. Her ultrasound reveals an endometriotic cyst, 5 centimeters in the left ovary, and for which she's undergone laparoscopic cystectomy. Bilateral tubes were patent. Now, how are you going to manage her, Meenakshi? It's on that side of the
Yes, ma'am.
table
Ma'am,
because we
she's-
can see them well.
She's endometriotic cyst already been operated upon, and we'll straight away will like to proceed for infertility treatment. I will like to go for an IUI for this patient initially for 2 or 3 cycles, and if it fails, we go for IVF. There is no role of post-operative ovarian suppression by using GnRH for about 3 months. So we would like to go for an IUI in this patient.
Okay. Dr. Manju, do you think IUI would be justified? What else should we know before we start talking of
We
an
should
IUI?
know about her AMH, right? Because she has been operated. You said tubes are patent, semen analysis normal, she's young. But yes, we know this also, that if you don't do anything, cyst might recur. She might have recurrence of endometriosis. But we also should explain it to her that fecundity is low. She may take little longer.
So basically, guarded opinion always in these patients because they are problematic and there is a high chance of recurrence, okay? So, all right.
So the important message we should give Dr. Sonia, that don't put them on, these diagnosis, for long time. Yeah, we are wasting time.
Don't waste the purpose of this cystectomy. She has to be managed actively before the endometriosis recurs again. Somnogoleza. Okay, all right. So here is another patient. Now this is all right. Let's start with it. 31-year-old lady presents with primary infertility of 3 years. Husband semen is normal. This I've done. Sorry. A 27-year-old lady married for 3 years. She's a known case of primary amenorrhea. Gets only withdrawal bleeding with estrogen progesterone and presents with primary infertility. Semen analysis is normal. Ultrasound reveals a small uterus of 5 into 2.5. ET is 2 millimeters. Small ovary. Day 2 hormones FSH2, LH1, E212, AMH 3.4, serum TSH and prolactin are normal. What is your diagnosis? Who is going to take this one? Yeah, you are left at the end. Why don't you take it? Yeah. What is your diagnosis and how are you going to manage this girl?
Ma'am, this is a case of hypo.
Yes.
And for this lady, she's 27 years old, married for 3 years, and primary amenorrhea. So first I would like to, I'm just seeing that the USG is revealing a small uterus. I would like to give her E plus P. So
You're
that
going to prime her.
Yeah,
You're going to
prime her, right.
Yeah.
And after that, we will do serial ultrasound in which I'm going to see the size of the uterus, is it increasing or what is the endometrial thickness I can get. Deciding on that only, I will think about doing the further management.
Okay.
If I'm...
Okay, so Tanya wanted to say something in between.
Tanuja ma'am, Tanuja.
No, Tanya wanted to say something.
Yeah.
Yeah. You have a mic in front of you. Tere paas hai. There's a mic over there.
From what I can understand in this patient, we are saying that
Mic.
already it seems she is having her, you're saying that she's having the withdrawal with estrogen and progesterone. So she's actually already had these cycles of priming.
Yeah.
So I think we need to go beyond and go into the injectables if we are going to give her that chance. What you've said is that surprisingly her AMH is 3.4.
Yes, and the uterus size, despite
Small.
taking estrogen and progesterone,
Yeah.
is still small. Still small. Yes.
Yeah.
So what will you do then? Jyoti, you want to say something quickly? This patient. Oh. One at a time, please take mic. Your battery is gone, ma'am.
High dose estrogen progesterone preparations for 6 months and then review for the uterine size.
Okay.
First find out what was given, how much was given.
Yes. You need to know the complete history of this patient before you actually embark upon doing something. And then after that, if she has taken a break in between, maybe that is why this has again regressed. She has taken it for so many years, but it has regressed again. So that could be a reason. And then what are you going to do next?
And maybe these patients are taking it like SOS basis. 4 mahine nahi hua to ek baar kha liya types aise.
Yes. Absolutely. Rita?
When she's ready for her pregnancy, obviously she needs her HMG.
So
We need to give gonadotrophins now.
So it goes without saying that first we'll be building up her uterus, looking at her lining. But what is important is since the routine oral ovulations are not going to work, so we will be giving her HMG for stimulation and then going maybe do a cycle of IUI but ultimately land into an IVF because that's how hypo respond.
And the stress is on HMG, not FSH only.
Absolutely, it has to be HMG.
Both FSH
Not
and
recombinant
LH.
FSH that everybody likes
No.
to give. All right, now 1 minute, one quick question. How long is this girl going to take to stimulate?
7 to 8 to 9 months. It
Huh?
would stimulate.
To stimulate.
Okay, it may take longer.
How long?
Maybe 2 to 3
Just
weeks.
a ball, yeah.
2 to 3 weeks.
Please, this is a very important message for all of you. What happens is, this patient takes a very long time to stimulate, and many of us, what we do is, you are not stimulating, you take a donor egg. So that is something which is said to these patients all the time, and they are, I think, the best ones. They stimulate very well and can even go into
Hyperstimulation.
Remember her AMH. She can go into hyperstimulation. Okay, so this is just to show you what you should be doing, chronic step up, aiste badhao and all that. And of course, you also have to give a luteal phase support in this patient. Over there.
So the next case is to Dr. Vandana. Dr. Vandana, this lady is 32 years, primary infertility for 3 years. Her AMH is 1.9. On ultrasound, which we usually do for infertility evaluation, we find a 4 centimeter endometrioma in the right ovary. How will you counsel this patient and how will you manage her?
Well, she's a 32-year-old, so the age is on her side.
Right?
Primary infertility is of 3 years borderline, and AMH is also borderline 1.9. Endometrioma 4 centimeter unilateral on one side. I would like to know first whether what are her associated symptoms, whether there is accompaniment of pain or
No, she
anything
doesn't
else.
have any symptoms. This we have diagnosed on a routine evaluation for infertility. She doesn't have any symptoms. She has a 4 centimeter endometrioma.
So if she has a 4 centimeter endometrioma and with a borderline AMH of 1.9, 32 years, trying for 3 years, well, the options are open for her. I'll be informing and counseling her regarding all the options available. We would like to have a check on her tubal status. If the semen parameters are normal, then the tubal status may be with an HSG, and if the tubes are patent, then she stands a fairly good amount chance of conceiving in an IUI. IUI can be tried for her. And as far as the surgery is concerned, I would like to withhold that till the time, of course, I will be telling her, counseling her, because doing a laparoscopy cystectomy may further decrease her AMH levels. So that may not be of benefit to her right away in the start. So I would probably go ahead with an counsel her. The choices are HSG followed by an IUI if tubes are patent. Of course with maybe gonadotropins or a letrozole. And if that is unsuccessful, then again the second comes whether surgery followed by an IVF, ART or ART followed by surgery. She has to be well informed that in case she goes for surgery, the AMH levels may further deteriorate.
You want to say something, Sunita?
So, I totally agree with Dr. Vanna, whatever she said. But in such cases, we should counsel the patients. If they are going for IUI, we have to limit the number of IUIs we are doing, and we should have a lower threshold of converting this to IVF.
Can I just say, if you find that tubes are patent, then why didn't she conceive in 3 years? Don't you think there's more than just tubal patency? She's been trying for 3 years.
That is why, ma'am, we should be lowering our threshold
So
and
should we
not
be
say
just
that.
going for IUI or we should be offering for surgery?
No, if the tubes are open,
Yeah.
if the tubes are open, 1 to 2 cycles IUI without touching her is okay.
Okay.
And then after that, we should look at the placement of follicles with respect to endometrioma if we are taking her for IVF also, to take a decision
That is evaluation for IUI.
Yeah,
Do you want
to
to say
take a
something,
decision.
Dr. Rita?
No, I think I agree with them, and we know that in endometrioma there are only 2 indications, and either she has pain or it is coming in your way when you are doing an IVF. Otherwise, operating in endometrioma just straight away is not advisable.
Well, laparoscopic cystectomy is still a very viable treatment for endometriotic cyst. I do not think that these are the only 2 indications. That's my personal
That's right.
We have to tell her that, though AMH will fall, but there is a chance that she may conceive on her own.
Exactly. If you're giving her IUI, I would rather say that if you do cystectomy, she stands a better chance than just doing IUI. IUI only putting sperms in. If her tubes were open, if everything else was fine, why didn't she conceive herself?
Ma'am, I think ASHRAE guidelines and most guidelines now do not...
I will show you
yeah.
ASHRAE guidelines. These are ASHRAE 2022 guidelines, by the way. And if you see, it says clinician may consider operative laparoscopy for treatment of endometrioma associated infertility, as it may increase the chance of natural pregnancy, although no data from comparative studies exist. Nobody has compared that like IUIs, but in patient who has good AMH, in fact, that she has a better chance of conceiving after surgery. GDT also recommends to perform surgery guided by the presence or absence of pain symptoms, like everybody said, patient's age, her own preference, whether she wants to do laparoscopy or not, her previous surgery. If she's had previous surgery, she may not be a good candidate for surgery, because repeated surgeries are never good. But in this case, this is her primary surgery. Presence of other infertility factors, ovarian reserve, and estimated endometriosis fertility index. Yeah, you want to say something?
Ma'am, if
Sorry, Renu. If you look at the guidelines, I know we all go by the ASHRAE guidelines, but look at the evidence. It's not a very strong evidence, you know.
Also, an endometrioma already means it's a moderate endometriosis. It's not mild or minimal, in which we guide for an IUI. I think it's very important because surgery is what people are rampantly anyway doing, and this is what I think we have to really tell, that this should not be our primary, we should be doing before that.
Ma'am, I
There
think
are
we can
studies
follow
to
this
show that-
first option
Yeah.
if the entire ovary is replaced by endometrioma and I mean like there are no excess, then that's a different thing, but otherwise.
Then you're only thinking of IVF. Anyway, let me finish this. So, although the value of IUI in infertile couple with stage 3-4 endometriosis with tubal patency is uncertain, but can't hear you? Okay. But use of IUI with ovarian stimulation can be considered. It is saying that in grade 3-4 endometriomas, it is not the best, IUI is not the best option, but you can consider a few cycles. So, because she is at least grade 3 if she has got an endometrioma. And ART can be performed for infertility associated with endometriosis, especially if tubal function is compromised, if there is a male factor infertility, or if the EFI is low. I hope everybody knows what is EFI. And if other treatments have failed, so if you've done 1 or 2 IUIs, although there's not very good evidence with the endometriomas, but still you can try 1 or 2 IUIs.
I think IUI with gonadotrophin stimulation is something we need to stress upon, ma'am. Not only IUI, with it has to be stimulated cycles.
Well, that if you look at IUI in general, Dr. Jyoti, then definitely with gonadotrophins, the success of IUI is much better. And in a patient who has endometriosis, you don't want to be wasting time, so I agree with you. I mean, although there is no bar, you can do with oral also. So,
Well, ma'am, basically, what has happened is either we have become endoscopic surgeons or we have become IVF specialists. We have stopped ourselves from being an infertility specialist. So that's the trouble. One of the people go this way, another half goes this way, and it all depends, accordingly. So if you become an infertility specialist, probably that's a good idea. When you have endoscopic skill also and you have IVF skill also, then your decision making is better always.
Yeah, sorry to interrupt you, sir, as I'm practicing both. So it becomes a dilemma for sometimes for the surgeon also.
No, then you can get the best of
then
both.
we throw the ball to the patient's court. What you want.
That is right. That's right. But at least you have that.
no, but you
privilege.
still have to counsel her, because you also know that the way you counsel patient also tends
Exactly.
to follow your
It is the
advice.
patient decision that matters the most.
Yeah.
If they want to go for the cycles of IUI, they can go for it because they will get the same results with both the things. And about this, one more thing I would like to mention about the AFC count, ma'am. In which site the endometrioma was?
That only comes when we're talking about IVF. So
Yes,
we're not
yes.
talking about IVF.
Yes,
yet.
yes.
So the next case, Dr. Sunita, this lady is 35 years old. She is for IVF. I mean, for whatever reasons that she has been counseled for IVF. The ultrasound now shows a 6 centimeter type 3 fibroid. She's totally asymptomatic, no AUB. It's a type 3 fibroid. Would you go for myomectomy? Very specific question before IVF.
So, ma'am, as per the size is significant in this case, and this is touching the endometrium, type 3. So, I would definitely like to address this fibroid. But the decision whether I want egg pickup first or embryo,
No, that's a different question.
So, we
That's a
can
different
always do an
question.
oocyte pickup first and then surgery.
Yeah.
But I would like to take out this fibroid. The size is significant and it is touching the endometrium.
So I agree with you that a lot of people will go with this thing, although it is not such a clear. Dr. Manju, you want to say something?
I fully agree with Dr. Sunita, because yes, I know you are a proponent that you have tried, but overall if you see, we know that, it is going to, they have done a very beautiful study. Renu, you must read that. So in a patients, where they have done a hysterectomy, so they did, study of endometrium where there was no fibroid, and same patient, and what they found in a mid-ovulatory cycle, that in the endometrium, endomyometrial junction, NK cells, they have decreased, and macrophages, reversal, where the fibroid. So they have very categorically said that it affects,
I totally agree with you, but that's all on a molecular level. ultimately we want a pregnancy. It doesn't matter whether there's a molecular change or not. What is important is that we get a pregnancy. And we know that pregnancies occur without removing them. Pregnancies don't occur. So probably if she fails IVF, then I would go. And if you want to look at the guidelines, and this is Canadian guideline 2015, it says there is fair evidence to recommend against myomectomy in women with intramural fibroids having excluded a submucous component by hysteroscopy and unexplained infertility regardless of their size. But this is 2015. The latest guideline is from the this is Australia and New Zealand Society in 2018, which says indications for myomectomy in infertile women are certainly submucous fibroids, symptomatic fibroids, there's no debate about that, and multiple failed IVF cycles. So even if not multiple, if you give her one cycle and she fails, probably that is a very good reason to do myomectomy. And there's no difference whether you do it laparoscopic or open. So all guidelines say that. Even there's another ASRM guidelines which says that. And I'm not disagreeing, but then I also have many patients where I did in such patients and they all conceived and delivered.
No, so controversial, it is a controversial,
Absolutely.
but any fibroid which is more than 5 centimeter, touching the endometrium lining, it should be removed. That everybody agrees.
Okay. Okay.
No doubt about
Right.
Just now presented such a beautiful paper on all this. Alka was also talking about the same thing. I think we'll have to go by the Indian guidelines, the Indian experience, I would say. So basically, it means that we have to remove if they are touching the endometrium.
Also the position is important, and there is a mass effect. We see that as well.
Yeah.
So I think Alka ma'am was very clear. Where is it? So
If
also
it
see that.
distorts the cavity, there is no doubt.
Ma'am, even
No,
if
no,
it's
you
final,
have
even
achieved
if it's in the
pregnancy,
mid position or
afterwards she
cervical.
aborts or she has a problem, it's not worth it.
No, that you have to talk to the patient if she wants to. I mean, she's happy with that. Yeah. Okay. Right. So next patient, Dr. Tanya. She's 30 years old. She is hirsute, so quite hirsute, obviously PCO, and she's trying to conceive for 2 years. So we gave her, this is a real case just about 2 weeks ago. So we gave her letrozole 5 mg from day 3 to 7 for ovulation induction. And day 10 ultrasound, like usually we do the first ultrasound to do for follicle monitoring. It showed no follicle was more, everything was less than 10 and just multiple small follicles.
So basically, ma'am, this is showing that she didn't respond to the letrozole that was given. And I think the key feature that along with the PCOS, I don't know the BMI, but what you've highlighted is she's hirsute.
Yeah.
And so I think that needs to be factored in as well.
Absolutely.
And the letrozole, now the point is in this cycle, we're still on day 10, but she's behaving as she's not responded as at all.
She's almost like day 2.
Absolutely. So what I can do in this case is add the gonadotropins, and at the same time, I would personally also add a bit of steroid, dexamethasone in clinical practice. And what we've seen with the hirsute girls, they do better with a combination. But what you have to do is monitor them quite carefully. The gonadotropin can be of your choice, whether you want to do an HMG or whether you want to do a recombinant FSH, it's up to you. But you've got to carefully monitor them, because with PCOS, we all know sometimes when we don't get a response, we get very excited and we start very quickly upping the dose. So we should have the patience. This patient actually is looking like someone who is not just started only. So maybe she's day 10, but what her follicles, and I presume that her endometrium is also very thin. So it actually means her estrogen is low, she's not just started, she's not just gone on. So we know the FSH window and we know the threshold has not even been started here. So add the two in my opinion. And there are many studies what you can plan for next cycle if she doesn't go through with the letrozole 5. But I think for this cycle, I would move on to a gonadotropin.
Dr. Arun, you want to add something quickly? No, just if you want to add something to what they said. Is there anything you want to add?
Yes, madam, steroids are not to be given from my side, because if you are looking for hirsutism, unless the androgens are from the adrenals, steroids usually do not help. I would like to add metformin for that matter. That would be a better idea. And obviously shifting on to gonadotropins, chronic low dose protocol. So that is how it goes on.
Okay.
So, can I just add, very
Yeah.
recent paper which has come up and then looked at the DHEAS levels, actually a May 2023 paper, and the compound was Dexlet. They give dexamethasone and letrozole for the hirsute girls, and they said the level of the androgens, as we're saying, the aim is to bring down the androgens from the adrenals, but there wasn't a level or a cutoff. So what they found that if you're not getting a response, they've added Dexa and they've added metformin if she is obese. Now here we didn't have that information.
There are a lot of studies where people have shown that even non-adrenal
Yes.
hirsutism,
Yes.
if you give low dose,
Yes.
it increases the response. Although it
And
should
it's a
not be
short
the primary.
duration. Absolutely.
Yeah, it should not be the primary thing, but there is a lot of evidence on that.
The level of the testosterone we see in that, serum testosterone.
No, it doesn't matter. That is totally useless. You get 3 testosterone, you get 3 figures. Anyway, the idea of putting of this case was to say that you don't have to wait for the period. You know, you can like give a stair-step protocol. You could either go on to 7.5 mg. You could either add like what she said, a little bit of steroid, a very low dose steroid, or you could go to HMG. So this was a case which we had last 2 weeks only back, and we actually went on day 10. She was 83 kilos, by the way, and we gave her 150 IU HMG from day 10 and gave her 6 days, and she had a nice follicle and she ovulated.
0.5
Yes.
milligram once.
But
and you can
metformin
give
will
it
not
for
act
10 days.
immediately.
Some people have given 7, some have given 14, but a very short duration.
0.5 milligram dexamethasone usually is the recommended dose.
Yeah.
Yeah. Yes.
Endometrium was thin at this stage when they started.
Yeah. After giving HMG, after 6 days, she had a nice endometrium, she had a nice follicle, she ovulated. So basically this is... Sorry? Yes, it has to be thin. Like I said, it is like a day 2 for her. So the message is that don't wait for period which delays and prolongs treatment time, and just go on with the next.
So one word of caution, I'm a very, very medical legal person. I don't know, I've become so. But 7.5 is not recommended as ovulation dose in India. And everybody is aware of the fact that it is only 2.5 which is recommended as far as the authorities are concerned. So instead of giving that stair step, please give gonadotrophins and be safe.
Very, very important point, because we have to respect the law of the land, so we don't want to get into trouble with that. Okay, so... Yes. That was the stair-step protocol that you can keep on increasing from 2.5 to 5 to 7.5. But here I think it makes more sense to give gonadotrophins, even otherwise, even besides the law part. So, without having period.
This is an old protocol which is even given for clomiphene.
Yeah, same. Actually, I just showed this slide was both for clomiphene as well as letrozole. You can simply, like they say, 5 to 7 days after the last pill, but you can do it little earlier also, and you start with the next dose.
Spiroff in his first volume gives this.
Okay. So the next case is to Dr. Jyoti. She is 34 years, primary infertility 3 years, AMH 1.8, semen analysis count. Again, this is a real patient which came last month. Count 1 million, motility 10%, no normal forms. She had IVF, DFI was high. She actually went through an IVF cycle which was unsuccessful in another hospital, and now she came to us for advice. What would you advise, Dr. Jyoti, if she came to you?
Ma'am, it is basically 2 things we are dealing here. One is 34 year, and we have to take care, we don't have to waste time, number
What is
one.
the most important
And
here?
the other thing is that we are dealing with the male factor here,
Yes,
the
severe
severe
male factor.
DFI.
Yeah.
Now this DFI, for that we have to counsel this couple, or especially the male, to go on a very good diet, reduce weight, have a exercise, cut
lifestyle.
down on alcohol, cut down on smoking. So basically, and also
Lifestyle modification, basically.
Exactly, the lifestyle modification has to be thoroughly stressed to this male person.
Yes.
And also, if there is any varicocele, we should also examine the husband to rule out any infections. So infections could also lead to this. So we have to rule out infections, we have to rule out varicocele, and if it is significant, then it needs to be operated. If it is grade 3 varicocele
Usually
leading on to
infections and
DFI.
varicocele don't give to such severe oats.
Oats.
Generally
Yeah.
it is.
But then I think lifestyle
Yeah.
and
Lifestyle,
antioxidants.
Antioxidants. yes.
Antioxidants.
And what else? I mean, this all everybody gives. What
Yeah.
next?
So now, once we are doing when we are taking them for the next cycle, so we have to
Do you want to do any other evaluation before taking her to next cycle, which has not been done?
Hormonal analysis is always indicated in severe oligospermia,
Yeah,
so
yeah.
that we can decide whether little bit of hormone is going to help the male, and semen culture you've already said, and a karyotype is also must.
and
We should
the
always do.
abstinence should be lesser next time.
Abstinence
So
should be less.
abstinence-
But he had lot of 2-3 samples. They were all same. So abstinence, of course, if you have too much abstinence, that's also a message. It gives you more dead sperms and less motile sperms. That's the main difference with more abstinence. But basically what we wanted to stress here and give a message that such severe oligozoospermia should have a genetic analysis, do a karyotype and do a Y chromosome microdeletion, because if the sperm count is less than 5 million, it is very important, not just for this patient but for his offspring, because this is going to be transmitted. If there is a translocation or a microdeletion, this is going to go to the male offspring. So very, very important to counsel. And also from the point of view of high DNA fragmentation, basically if all this lifestyle and all modification antioxidant just doesn't help, you can ICSI everybody will do in such a count,
next
but you can actually take out testicular sperm.
Testicular sperms.
Because the fragmentation probably increases as the sperm travels from the testes to the ejaculation. So a testicular sperm may have lower DFI and may be considered in this cycle.
Or
though
if
it
we
is-
are not doing testicular sperms, then we can try microfluidics or maybe some magnetic.
no morphology. Yeah. So ICSI, but with addition of surgically. So the next case, किसके नाम है? अच्छा, to Dr. Tanuja. So that's the last case. अब ठीक है अब ऐसे. Okay, so she is 39-year-old, known PCOS, AMH is 3.4, sort of borderline, BMI is 24, not so bad again. Underwent 2 cycles of IVF. This is also a real patient we saw last month.
Yes, ma'am.
Was treated in a hospital in Delhi. She had 2 cycles of IVF, had severe OHSS in both, had multiple peritoneal tappings, was admitted both times for 1 week. First cycle she got FSH and HMG, and I actually tell you, I looked at through her papers very carefully. She got 300 units, 150, and she went into severe OHSS. The next cycle they started with clomiphene citrate and added lower doses of FSH, yet she went into severe hyperstimulation. What do you plan to do? Anybody, or you can take?
Hello. She is a case of severe OHS by this information, and the other thing I got from this is that she is a hyper-responder. So definitely she is a hyper-responder. I will plan another cycle for her. For this cycle, if we have retrieved the number of oocytes, I would like to know the number of oocytes. Then we can plan a freeze ET for her, elective freeze ET for her. And also, ma'am, I would like to know what trigger was given to this patient, because if
Whatever was given, now you have to plan.
Yeah.
You may not get a patient with all the details.
Yes.
Dr. Rita, you want to say
For
something?
the next cycle, I would like to get her on GN antagonist and a trigger of agonist, definitely.
Absolutely. That is the least we can do. But anything you want to add, Dr. Manju, Dr. Rita? Metformin.
Yes, ma'am.
She
Dopamine
was
agonist.
already on metformin. She was on metformin. All this throughout she was on metformin.
Dopamine agonist we can
Dopamine
add,
agonist
but
don't
they are
help.
not
They
having a
don't
good
help.
evidence.
Can I say
Yeah,
something?
please.
So there are few principles which we have to always follow in such cases. So which includes metformin, as all my colleagues said, and then the doses have to be very low right from the beginning, and giving CC followed by FSH
Even
is
if you
a
don't give
better
CC
choice.
very low doses,
Yeah.
it may take longer, but
And
do
we should not
push.
combine
Yeah.
the two. And we have to follow antagonist protocol, then freeze all, complete suppression, and do subsequent cycle of
That we
frozen
do
embryo
for all
transfer.
PCOS. But
And
now
the-
the interesting part is that this patient came to me and she says, I do not want to have another IVF cycle. I've just had enough. I want a donor cycle. She requested me for a donor cycle. Are we justified? Anybody?
No, we're not justified.
But she doesn't want to have a cycle
Yeah,
on her own.
if she had such a bad experience that she doesn't want to go through, I will be with the patient on that.
Patient
I
says,
think,
I
ma'am,
don't
we are
want to have
justified
another
to give
IVF
donor
cycle.
cycle. Why not? If she is asking for it,
Exactly. She says,
she's
I
having
don't
such a
want-
bad experience. I have seen patients going into ICU and getting AKI, then what is the fun?
So that was the interesting part, that the patient requested. She said, I want a donor cycle. She never had transfer. No transfer. She went into severe hyperstimulation.
Case of early OHSS.
Nahin.
Ma'am, we do use it, but it does not have
See, capgolin,
enough evidences.
better than capgolin is letrozole. Start letrozole. But I don't know that. I don't know whether they started or not.
Letrozole only. Only letrozole. 1 or 2 follicles at the most and do an IVF with that. Only 1 or 2. Minimal stimulation and then maybe we could offer her. But the only problem is late OHSS. We can't guarantee that, you know. We can always circumvent the early but not the late. But of course, if her E2 levels are kept low, then she may not go into late.
Ma'am, may I know the
She will go
trigger?
into it. Yeah.
But still, late OHSS will not be that common. If she has low E2 levels throughout, then she won't go into it. After all, if she gets pregnant herself, then it's like saying she might go into OHSS. वो तो होगा. So that's it.
I
Let's
think
finish
she
it.
needs a very good counseling and a confidence,
इसको छोड़ दो
and
last
we can start her on a minimal stimulation IVF.
छोड़ दो.
And in case in the
last case
mid-cycle,
छोड़ दो,
if
table
she feels that she's again going towards hyperstimulation, we can always give her a chance to cancel the cycle.
There was a study of optimists that went on 2 groups. One was given 150 and the other was given 100 to see the severity of OHSS and the results. So they just found this, the severity of OHSS reduces with the gonadotropin dose, and
Obviously.
definitely the live birth
So
rate
this patient
same
you will
in
not
both the
even give
groups.
150. This patient you will start on 37.5 or 75. You know, you have to touch her very, very
That is the main thing. I think we should learn from this.
quickly. 1 minute, just one sentence.
Yes, ma'am. Long time back, in fact, then we started with oral ovulogence, 50 milligram. No, we were starting with 50 milligram CC, and patient had OHSS with 50 milligram.
Yes, yes.
And for the first time, I had to shift to 25 milligram, like in, in females.
Absolutely.
And that is one. Second part, one point I want to always make is, please do not always, consider AMH as the gold standard. Please always do AFC also, because there's lots of discordance. Many studies are there. There's a lots of discordance between AFC and AMH and FSH also. Do not consider FSH. Ideally, one always finds that FSH is high and AMH is low. It's not like this. In many patients, all these three are not exactly interdependent and no correlation. So you have to be very careful in interpreting all these three.
Exactly.
And I always consider AFC to be the best, because you can see with your eyes everything, and that may or may not respond. But that
Dr.
it is.
Rita. But I have had a patient where the AFC was not so much, but AMH was 3.6, and she went into hyperstimulation. Dr. Rita.
I think
was the other way
it must be years since we've ever seen a case like this, and it has to be an HCG trigger, whoever gave it by mistake or by ignorance. So we've seen 20, 30, in an era, but I don't think this could be. So freeze all, antagonist protocol, and then agonist trigger. I don't think we'll ever face something like
Now, please, not on the last case. We want you to
No,
give.
ma'am, Madam said
Yes.
just now that HCG trigger, and they have never seen thing. I have seen
With the
very,
Jacob
I'm not
Hotel
going to say which IVF center, prestigious. They've had antac protocol,
Yes.
agonist,
Even
and
with
had
that.
an ascites, 21 days they were hospitalized.
Yeah, it is possible even with agonist. It's not zero. Now, my request to all of you, one last message, not on this case, but otherwise. Dr. Khemani, you said yours. Oh, now we are going to start from there.
So
One
what I want to emphasize
second.
that, you know, many times couple they come at the age of 39, 40, right? Married for 6 months and you want to try for IUI. Tell them, after the age of 40, success of IUI is only 4%. Is it worth it? And then leave it to the patient.
Absolutely. Thank
I
you.
think my message is that gynecologist should send the patient at the proper time rather than giving 12 cycles or 14 cycles of the CC and letrozole.
Very good message. Next.
I think only infertility specialists should be dealing with the infertile patients. We should be doing sort of mutual practice where not all infertility should be dealt by general practitioners in this era. Yes, so we should be doing a guarded practice, and whenever we should have a limit where till that time we should be trying and then give it over to the experts.
Absolutely. Stop. When to stop? Everything. Chalo. Next.
Counseling is very, very important in infertile couples, and the morale, etc., should be raised. And most of the patients, they conceive after a good counseling and visiting the clinics.
Thank you. Thank you.
That has been.
Meenakshi.
Ma'am, I just want to say for general obs-gynae practitioners that we need to screen the patient of infertility, and whenever there are high-risk factors, any simple high-risk factors like an age more than 35, obesity, all these things, they should refer to the infertility specialist earlier rather than managing it themselves.
Okay, next.
And I completely agree with my seniors and colleagues about this, that what matters is the age. What your result you are going to get at the age of 32, you are not going to get at the age of 36, 38. So the time matters the most in infertility.
Next. Next is this side. Next is this side. Yeah.
So I would say that keeping recommendations in mind, whenever you are treating a patient of infertility, individualize the couple, counsel her properly, and you have to give all the options, take an informed consent. She should be a part, the couple should be a part of your informed decision, and third party reproduction should be the last resort. Whether it is a donor egg or a surrogacy, it should be kept as a last resort for any infertile couple.
Next.
I'd like to say that I think all of us should know how to examine and see our own patients ourselves. And I think just like we're empowering everybody with various modalities, I think each infertility or each young gynecologist should also know how to scan their patients, to examine their patients. And Sharda ma'am has said this, always start from history and examination. Sometimes we come across patients who've had multiple failed cycles of IVF and she's not had even a basic PS and a cervical cancer screening.
Don't forget to do a pap smear.
Please, absolutely, the patient is entirely yours, both the woman and the man. We must examine both. I mean, when we say that we're a complete physician, we're a gynecologist, we're an infertility specialist, all in one. So we must know how to examine our patients ourselves, and we must do our scannings also ourselves.
Next, Sunita.
So I just want to convey this to the audience that since when this new ART law has come, it is a must that all of us, all obstetrician and gynecologists should be aware of at least what are the rules about IUI, because IVF, no, not that everybody is doing, but because everyone was doing IUI and now there are so many restrictions, the law has to be very, very clear what all you can do, whether you can handle the sperms in your clinic only if you are registered. Otherwise, take help of your colleagues who are working at IVF or who have taken registration, take their help, get associated with them, and then properly do, because you don't know when you can get trapped. So, because, you know, I have seen even now there are big hospitals, people talking about this, that okay, have you stopped, has Fortis has stopped doing IUIs, general gynecs have stopped doing IUIs, we are doing. So I think even now when we are sitting almost a year from ART law, it had come June last year, even now the clarity is not there. It is a must to know about this. Everything is available online. Call your colleagues who are working in the field of fertility. If you are not aware, please call your colleagues and know about it and practice this very properly. Thank you
I
so
think
much. Thank
very,
you.
very important take-home messages given. And with this, we wrap up this panel on infertility. And many, many thanks to our esteemed panelists and experts for giving us insight into dilemmas and challenges in infertility.